Hello, I'm Professor Robert Dunn. We'll be discussing an approach to bone tumours. The learning objectives are for you to be able to describe a lesion on X-ray, to recognize the aggressive lesions, and have a general approach to the management of both benign and malignant tumours. A useful mnemonic for describing a lesion on X-ray is what we call SMEC pH. S to the power of 3 being site, size, and shape. The site would be which bone it is, where in the bone it is. The size would be a numeric value in centimeters, taking the size of the bone into account and guesstimating from there. Shape, if there is a shape. Assessing the margin, is it well marginated or poorly marginated? This is quite important, as if a lesion is very metabolically active, such as a malignancy, the margin will be poor. If it's slow growing and inactive, latent, like a benign tumor, there may be a very well demarcated margin. And then you need to discuss the extent, whether it extends through the bone, causing a fracture, from the metaphysis into the epiphysis, etc. We make an educated guess as the contents, whether this is soft tissue, fluid, if fluid, blood, CSF, synovial fluid, and then signs of response. Is there sign of a periosteal reaction or bone healing? Here we presented with an AP and lateral X-ray. What is first very important to recognize is that this is an X-ray of an immature skeleton, in other words, a child. This is easily recognized by the prevalence, or not prevalence, but the persistence of the growth plates. See the growth plates here? At the humerus down here, you can see an incompletely formed radial head. So this is an example of a child. That already is very important. As we know, metastatic and malignant disease is far less common in children and more common with age, as our DNA system breaks down and our immune system breaks down in terms of recognizing aberrant DNA. So here we have a child, we have a humerus. You can assess that he has a chest cage, he has the scapula, here's obviously a humerus, there's AP from the front, here's his lateral from the side, you can see the elbow joint, and quite obviously there's a lesion. So we have a lesion in the left humerus in an immature patient. This lesion is at the proximal diaphyseal area, or you could say junction between the metaphysis and diaphysis. Size would be in the order of 2 by 2 by 2 centimeters. Clearly there's magnification to the X-ray, and one needs to take that into account, and that will come with time when you know roughly what size bones are at relevant ages. Shape, one gets the feeling that it's cylindrical in shape. Then the margins, well marginated. You can quite easily see the margin, the junction between the contents and the residual bone. E for extent, you can see it extends through the cortex on the lateral aspect and the medial aspect. You can see here this thick sclerotic line as opposed to the medulla, and the thick sclerotic line representing the cortices. This is a tube of hard outer bone and medullary bone inside. And you can see this is attenuated here. So in a three-dimensional way, you can see outside, inside, anterior, posterior. So this lesion has eroded away the cortex cylindrically. So there's an extension, as you can see, through the cortex, both laterally, medially, posteriorly, which implies that there's a fracture. Now, in this context, our fracture is called a pathological fracture due to an underlying pathological process. C for contents. This is a lytic lesion. You can see the normal bony architecture is destroyed and replaced with something that is more like air or soft tissue. You can see here, this is an axilla, this is air, and this is the skin and soft tissue and muscle over here, and that's bone. So you can see that this density is somewhere around soft tissue or maybe air with residual bone blocking it. So our contents in the lytic tumor would either be soft tissue or fluid. If it's fluid, it would be blood, proteinaceous exudate. If close to a joint, could be synovial fluid. If close to spine, could be CSF. And then signs of periosteal reaction. Posteriorly, we can see signs of healing or periosteal action over here. You can see the fracture that's occurred, and now there's some bone formation here as the periosteum is lifted up. This is an example of a simple bone cyst, which is a benign lesion, typically seen in humeri of children, and that's why it's important to recognize that this is a child. It's often it presents when it fractures due to it weakening the bone, and the child, or while playing or being yanked on the arm, fracture. Else it is incidentally located when a child has an x-ray, for a chest x-ray, for instance, for some other reason, and it's noted on the side. If left alone, it will heal and slowly involute. If we choose to do something about it, we can inject steroids into it, or we can open it and curette it out. Here again is an example of an immature skeleton. There's a open growth plate. This is an older child because you can see now the radial head is formed. Here we can see the capitellum. So this is probably a child 12, 14 years of age. You can see it's a multiloculated bone cyst. You can see there's multiple bone cysts. So again, we've got multiloculated bone cysts in the left humerus of an immature skeleton. The size will be a bit bigger now, probably 3 by 6 shape. There's some round shaped areas, margins easy to see, well marginated. Extent again breached the medial cortex, which is probably why the child presented with a fracture, pathological fracture. Contents again analytic, destruction of bone. And now to decide whether this is soft tissue or fluid, we look at this falling fragment sign. You can see this falling fragment sign, which is one of the pieces of bone inside the cavities, which is broken off. And when we x-ray humerus, the child is seated, and there'll be a fluid level, and that bone will lie in the fluid. So the fact that you see this bone indicates that there's fluid in here. And this is an example of a multiloculated bone cyst, and our management would be to go and curette the tumor out and pack it full of bone graft and get it to heal. Here's an example of a distal femur and proximal tibia. Left has been marked, so it's a knee joint, left knee, and you can see this obvious lesion medially. We know this is medially because there's a fibula, so that's lateral. There's medial, so the medial femoral condyle, and posterior. Here we're looking at a lateral, so our posterior. So we know it's a posteromedial lesion of the distal femur. We know this is epiphyseal because it's right on the joint line, so the epiphysis, the physis would have been about here, and this is distal to it, so it's epiphysis. Size difficult, maybe 4 by 3 or 5 by 4 centimeters. Shape more difficult to describe. The shape of the margins are poorer here. It's difficult to see the margins as clearly as we did earlier. The contents are mixed. There's areas of lysis and sclerosis, so we talk about a mixed picture. And you can see over here that there is evidence of periosteal reaction. This is called a Codman's triangle, C-O-D-M-A-N. Codman's triangle is due to rapid growth, lifting the periosteum and normal bone forming underneath. Now, this is a more concerning tumor. There's more metabolic activity, the poor margin, the rapid growth indicated by the Codman's triangle, and we would be concerned about whether this is malignant or not. After investigation, this lesion actually turned out to be benign and is in fact an example of a giant cell tumor, GCT. The other term for this is an osteoclastoma, O-S-T-E-O-C-L-A-S-T-O-M-A. Osteoclastoma would be the same terms, giant cell tumor, GCT, or osteoclastoma. And they involve the epiphysis of bone. That's why it's important to recognize the site, because it's one of the few tumors that involves the epiphysis of bone. It's an interesting tumor. Although classified as benign, it is locally aggressive and destroys the joint and will cause significant dysfunction. It also tends to recur locally and is more difficult to eradicate, and in a very small number of cases can in fact metastasize despite being classed as benign. We divide our benign tumors into latent, active, and aggressive, and this would be an example of aggressive. How do we treat these more aggressive benign tumors? Well, they require surgical resection Obviously, if we can retain the joint, we will do that. Often we'll have to resect the whole joint and replace it either with a false joint, with arthroplasty, a cobalt chrome joint, or an allograft bone joint. If possible, we can retain the cartilage and resect the tumor. We then use adjuvant chemotherapy. So at the time of surgery, we will apply either phenol to kill the remaining cells, or liquid nitrogen, which is the most effective, which freezes the bone in that area and kills to a depth of 7 millimeters, or burn it with methyl methacrylate, which burns to about 4 millimeters. It's a bone cement we put in. And then we'll need to reconstruct the joint either with, as I said, with biomechanical methods such as arthroplasty with metal or allograft reconstruction. Here we have a patient that presents with back pain, and he has a poor x-ray, which is a typical x-ray you may receive in a day hospital environment. What you do notice when looking at the pedicles and relationship of the spinous processes, that the spinous process typically it should be in the middle of the two pedicles. As we come up here, it's more to the side, so there's a mild scoliosis, but this is a relatively normal spine. What one would do is investigate the patient with a full blood count and ESR to see if there's an infection, because TB spine is obviously always on the cards in our country. But this patient ended up having a normal full blood count and ESR. A useful investigation is a nuclear medicine investigation, a bone scan where we use technetium 99 labeled phosphate. This comes prefabricated, is injected into the vein. The phosphate will obviously travel in the venous blood to the heart, through the arterial system to the bones, where the phosphate will be absorbed metabolically into the bone. The attached technetium 99 allows us to see where this phosphate is using technology, and you can see that after 2 to 4 hours, all the bones have taken up this technetium 99 phosphate, but where there's increased metabolic activity, there's increased density. And we now can see this is roughly in the area on the right at T9 or 10, and we can do a localized CT scan and identify this lesion. This is typical of an osteoid, osteoma, which is a small benign tumor of embryonic tissue, which causes inflammatory mediators to be secreted, causes significant pain, wakes people at night, often responds well to aspirin or anti-inflammatories, and if persistent can simply be removed surgically with a small focal curettage. Here we have an example of a tibia, fibula with an exostosis. Here's a lesion on the outside of bone, an exostosis. You can see the normal trabecular bone extending into its pedicle with abnormal tissue. This is calcification. Notice the difference between calcification and ossification or bone. Bone is a living organ with trabecular pattern constantly being reworked by cutting osteoclasts and relaid down by osteoblasts, whereas calcification is mineralization usually of cartilage, and where you see this it's usually cartilage, so we know that this is bone and cartilage translated to osteochondroma. So here we have an example of an exostosis, also known as an osteochondroma. These are thought to occur from a bit broken off piece of physeal plate, growth plate, and that's why they're always located near joints. At one point there was a growth plate here, a small piece of cartilage broke off and formed this exostosis. If you understand that, you'll understand that as the patient grows, it grows. When the patient is mature and the physis is closed, it should stop growing. And one of the signs of malignant transformation, which occurs in about 1% of cases, is when they continue to grow or are painful following skeletal maturity. Here's an example of a phalanx where there is a lesion within the bone, an enchondroma, enchondroma. Again, well marginated, so you would think this would be a benign tumor. It's lytic with some calcific stippling. Calcification again occurs in cartilage, so we know that this tissue is cartilage, and this is an enchondroma. You get syndromes such as Ollier's disease, where there's multiple enchondromatosis, which distorts the growth of the phalanges and can cause deformity. This is a pass-fail X-ray. Should you ever see this and not recognize it, you'll be in trouble. This is obviously a distal femur. You can see the physis. You can see the physis of the tibia, so this is a distal femur with a knee joint. You've got the most osteoblastic or sclerotic lesion you're going to see involving this distal femur. You can put a measurement to that, 10 centimeters to 5 centimeters. It's difficult to see the shape, although it's well marginated at the bottom here where it strikes the physeal plate. It's extending up the shaft in the medulla. It's extended beyond the borders of the cortex. There's sun ray spicules. There's a Codman's triangle over here. You can see that's growing rapidly. This is going to be a big mass over here. It's lifting up the periosteum and causing normal bone formation. This is osteoblastic. Its contents are bone. It can only be bone to be this white. And we see the signs of the periosteal reaction. This is clearly an aggressive tumor. It's a malignant tumor. And our approach is totally different. We now need to work this patient up both generally and locally. We call this super staging. We've got to see, has this tumor spread? In other words, has it metastasized? The reason being, this will allow us to prognosticate on the natural history of the tumor and, in fact, the death of the patient. And clearly, when we allocate resources to such a patient, it's based on the potential outcome. In a patient riddled with metastatic disease, it's pointless to try and resect and reconstruct such a limb. The patient is going to die in a very short period of time, and that patient is best managed with palliative care. Should the patient have no metastases and localized disease, which is resectable or controlled by amputation, one would invest more resources into that patient. So it's extremely important to stage them. We stage them by doing a chest x-ray. Should we see metastatic lesions in the chest, it will confirm widespread disease, but we will only pick up lesions of 10 millimeters or more. Should the chest x-ray be clear, one would do a CT chest to look for smaller lesions, which we'll pick up at about 2 millimeters each. We perform a technetium-99 bone scan to look for other lesions in the body, do a clinical examination or ultrasound of the abdomen to see there's not visceral disease, and do blood tests to assess the patient's general status. Are they anemic? Exclude the differentials of infection, obviously, so look at the white cell count. Look at the calcium, because calcium may be very high in any bone tumor and the patient may die from an arrhythmia during an anesthetic from this. It's very important to recognize hypercalcemia if there is. And there's a multitude of other white cell markers one can do to identify what type of tumor it is in collaboration with oncologists. Once we've done general staging, we do the local staging. The local staging is to identify the extent of the tumor locally, how many compartments does it involve, because we need to decide whether we amputate the limb to control this or can we do limb preservation surgery. Limb preservation surgery would involve resecting the tumor on its own with a clear margin of normal tissue, but retaining adequate function for the patient to benefit from the use of that limb. So in other words, if the tumor extends into the multiple compartments, muscular compartments of the limb, involving the vessels, the blood vessels involving the nerves, resection would have to involve all of that, and the patient would be rendered with a flail limb without any sensation and power, which is pointless. Should the tumor only involve the bone itself and no musculature, we can resect the tumor, retain the musculature and nerves, and have a functional limb. We therefore use an MRI to assess the tumor, MRA to assess the vascularity, and a CT scan to assess the bone. We will then need to perform a biopsy to confirm what type of tumor this is. It's best done by the definitive surgeon who will understand the safest way to access the tumor without violating the other compartments, the other muscular compartments, using a longitudinal incision, because when it comes to the definitive surgery, the biopsy tract needs to be excised, and to close a transverse incision on a limb requires a lot of tissue and possibly a flap. We need an adequate samples, multiple samples, some from inside the tumor, which may be necrotic and not representative, from the edge of the tumor, which may be reactive and not representative. So we take multiple samples to ensure, to increase the likelihood of histological confirmation. We then, in collaboration with oncologists, will go through a period of neoadjuvant chemotherapy for the patient. This is where chemo is given to the patient prior to surgery, using drugs such as cisplatin and adriamycin in osteosarcoma. And then at surgery, resecting the tumor either by amputation or limb preservation, we send that tumor off for grading. The number of cells is then counted, and the ratio of dead to live cells are calculated. Should there be greater than a 90% necrosis rate, in other words, 90% of the cells are dead, we would consider this effective chemotherapy. Should there be less than 90% killed, we would then regard this as ineffective therapy, and the oncologist would step up the medication they're using with increasing side effects, but increasing effect against the tumor, hopefully. Here's an example of a proximal tibia where there's erosions, and you can see there's previous drill holes here. This is a very sad case of a child. You can see the facies are still open, indicative of a child who's presented with a warm, swollen proximal tibia. Frequently, these are misdiagnosed as a osteomyelitis due to Staph aureus. They can often have a moderately raised white cell count. There might be a little bit of pus when you incise this area, and many times it's confused and treated as a osteomyelitis despite negative cultures. And with recurrence, it becomes obvious that this is a tumor. Here's an example of a proximal femoral fracture. You see the large lytic lesion over here. You see the pathological fracture. You see this is an old patient due to the disc degeneration, osteophytes. In this case, it's likely to be a metastatic lesion from CA lung, colon, breast, prostate. In this case, not unlikely to be prostate, because prostate tends to give sclerotic lesions, lytic lesions more commonly from the others. The approach here is far different. We'll try and identify the primary with a clinical investigation, CT scan of the lungs, and then primary fixation of the femur with samples taken from the lesion to confirm the histology. This is a very old technique. Today we would use devices putting screws up into the neck to prevent a subsequent involvement of tumor in this area. We would then have the tumor irradiated, and by definition metastatic disease is not curable but can be controlled depending on the type of tumor and the stage of disease with chemotherapy and local radiotherapy. Here's an example of a patient that presents with increasing myelopathy. When you look at the spine, you see the spinous processes. You look for the pedicles, which are the eyes of the owl, and the spinous process, the beak of the owl. You see the pedicle, missing a pedicle, missing a pedicle, missing a pedicle. There's a lesion that's encroaching onto the spine and spinal canal. You can see the hilar lesion in the lungs here. This is a patient with CA lung, local erosion into the spine. This patient will get palliative care and probably have death within the next few months. Lastly, here's just an X-ray to show you advanced disease of the right low limb girdle. This is not a tumor, despite it looking like a tumor. This is an infection. It's very unusual for a tumor to cross joints. Generally speaking, tumors will stay on one side of the joint. When you see involvement both sides of a joint, it's more likely to be infection. Clearly, this is an infective process that's taken a long time. You can see the secondary increased density of bone by Wolff's law. When you destroy bone slowly and increase load on the residual bone, you can see the increased density. So this bone has had a long time to compensate. So this disease is a slow, insidious process. Therefore, bacteria like Staph aureus are unlikely to cause this, because that would cause septicemia and death long before the bone would have a chance to do this. This process may be caused by something like TB, although TB tends to cause ankylosis. And this is, in fact, an example of a parasitic infection, echinococcus, or also known as hydatid disease. So just remember, every bony lesion is not a tumor. Tumors do not tend to cross the joints. Thank you.